The purpose of today was just to review some of the symptoms, to give really practical advice to how are we going to try and get on top of this symptom burden. When we look back and we look at the scorecards and we're really tracking the progress, there has been so much progress made in so many different areas, but it's the symptom management that seems to be a bit of a hurdle. So we looked to see what the most common severe symptoms are, and these three were absolutely the top three. And then number 4 would be restless legs, but that was quite substantially lower. So these are the three that we're going to talk about, but we can talk about restless legs briefly because it really goes very well with these three. So what we're going to do is we're going to just really try and understand what's the philosophy, because if we can get on top of these three symptoms, those three symptoms alone are going to really minimize our patient's symptom burden. So if we take a step back, what are our treatment management priorities or principles? So we want to keep in mind that we're only treating symptoms if they're impacting function or quality of life. And so that is usually someone that rates it a 4 to 6 out of 10 would be moderate, and 7 or higher is severe. And so we're trying to, at least if they're in severe, get them down. But we're absolutely going to be tracking all of the symptom burden. So what we might be seeing is that you're actually getting on top of moderate symptoms. You're just not getting on top of severe symptoms, because that's where that's what we're actually looking at right now. So the first thing is we don't want to jump to medications. We always want to assess and treat contributing, especially reversible factors. And sometimes we forget what might be exacerbating all these symptoms. There are many different things that can, and having a go-to place where you can just quickly look at the list, what are those contributing factors, and address those. And that's all on the pathway. But if you're not using the pathway, it may not be something that you're holding in your head all the time. And then, only then, would you then go to other non-pharmacologic treatments? So they would be the things that you tell your patients that they can do. And actually you could do those steps 1 and 2, you can actually do concurrently. And then for example, if it's pruritus, you've got your topical. And at the end of that, only then would you jump to medications. We're trying to make this safe and a very stepwise approach. The other thing to keep in mind is that throughout this whole process, we have patients on very different trajectories. And the reason why we have this stepwise approach is a lot of those pharmacologic agents do come with adverse effects, and we'll talk about those. But if we're really wanting to optimize function, cognition, and everything else, if we can get on top of symptoms without increasing their medication load, that's great. Near the end of life, it's not as important because you tend to have to need to use medications near the end of life, and they tend to be more bedridden, and you're not worried about the functional abilities quite to the same extent. So why don't we go just using itch as an example, and keep in mind that we have all of these one-page handouts for patients for all of the non-pharmacologic. So if we were just to pull up itch on the website, the first thing it's going to say is rule out contributing factors. So for itch, we've actually got this. This is step 1 and step 2 is actually combined here on this one, because there's not a lot of contributing factors. It tends to be anemia, and we sometimes forget that anemia can contribute to itch. But the bottom line is most of our patients have their anemia pretty well managed. So the main next go-to would be calcium and phosphorus imbalance. And you're looking primarily at high phosphorus or a high calcium phosphorus product. So it would click, you could click on those guidelines if you didn't know, but of course for you, this is not an issue. And then just a reminder that drug sensitivities, really dry skin, contact dermatitis, other inflammatory diseases, we want to take a look at their skin just to make sure there's nothing else going on. But at the end of the day, for pruritus, good skin care is going to be critical. So this is where it's so important to actually sit down with a patient and walk through that one-pager. And this, out of all of the patient one-pagers, I think is the most effective. And so really talking to them about if they can bear bathing as opposed to showering, that lukewarm soak for 15 minutes, and literally as soon as you get out, you barely pat dry before you're rubbing down with lotion. The lotions can't have perfumes and lots of alcohol. They should still be water-based though, so it's that soak and seal philosophy. And then keeping a humid home environment, keeping them cool, loose clothing, all of that makes a difference. And then other things, avoiding, and I talk about this all the time, avoiding scratching, but we don't say, don't scratch, you know, because that doesn't help them. They're going to scratch. So I actually look at their nails. You know, you make sure that they've got their nails cut, they're short, they're filed down, and they're smooth, and you show them how to do that massage. Press, massage, because a lot of our patients with severe pruritus, they're excoriated, and once they're excoriated, that is the cause of the pruritus now. It's that healing. You know how itchy you get when you cut yourself and you get the scabbing? So sometimes the uremic pruritus may have gone, and now they're just perpetuating it, and it's trauma which is causing the pruritus. So they've got to stop that. And if they're scratching at night, they can get those little very thin gloves. Use it as a little mini spa. Tell them to put the lotion on before they've got their, you know, go to bed, put their gloves on, and you just get those very thin linen gloves. And so all of those things can be very, very beneficial. If that doesn't work, then we want to go to our topical agents first. Now, this is something that you can do prior to going to the nephrologist as well. So all of these have to be ordered with the exception of Pramoxine if you get it as over-the-counter Gold Bond. And some patients will get benefit. If they are still severe, I'm not sure, but this is something that you can try pretty much right out of the gate. And then if it's a smaller area, say they've pretty much got it under control, but just on smaller limbs, then you can try one of these other creams. Because we don't use them very often, and we're so quick to jump to medications, we don't have a lot of experience, and it's really hard to prescribe something that you've never used before. So what I advocate for is picking one or two that you're going to try, and you may decide as teams. One or two teams pick one, the other team or a couple teams picks another, and between the two of you, you try out two different creams. See what works, see what the patients like. So you can have Pramoxine or at least Gold Bond in your back pocket to use first. And then say, maybe I'm going to try Pramoxine with hydrocortisone as a prescription, and maybe capsaicin, or I'm going to do methylcamphor and phenol. Just pick one or two between the lot of you and go with that. My recommendation is Pramoxine to start with because it's easiest. And then menthol, camphor, and phenol. You can prescribe them as single agents as 0.3% each, or you can put all three together in one cream as 0.3. I would suggest maybe starting with all three. 0.3%, a combination cream, and just maybe saying, I'm going to try that, or Pramoxine with hydrocortisone, and maybe they're your first two prescription ones to try if over-the-counter doesn't work. So it's a recommendation only, but to start gaining some experience with creams that you then feel comfortable prescribing, and then you're holding the nephrologist by the hand a little bit as well and saying, these are the ones that we're going to try out in clinic. So the choice is yours. That is a recommendation. And then, and only then, would we go to drugs. So pharmacotherapy. And our number one go-to is gabapentin. I've got pregabalin there as well because it is a similar drug, but we know how expensive it is. It's not formulary. So we're going to use gabapentin for our patients. And doses are low and you titrate slow. So do I start at 50 milligrams? No, I don't, unless the patient is itsy bitsy, absolutely tiny and frail. And at that point, if it's 50 milligrams, you're going to have to call the pharmacy because they're going to have to make a suspension for the patient, right? But otherwise, for someone that's a regular size, you can pretty much start at 100 milligrams, your maximum dose being 300, and never titrating more quickly than once a week. So what are the main concerns with gabapentin, though? Right, drowsiness. And drowsiness is going to do what?
Well, it affects their balance.
Absolutely.
Yeah.
Absolutely. So one, it can make them just drowsy. They're tired during the day. They don't want it. Or they actually fall and break something. Or they go cuckoo.
Yeah.
They can get toxic and get quite delirious on it if you give them really high doses. So we have to be careful and treat it with respect. So if you give someone 100 milligrams and you find that, oh, you know what, they're getting really loopy on it, but they're not too high of a fall risk, there are some things that you can do. So what I tell them to do is, one, I let them know right away, these are the side effects, expect them. The chances are you're going to get them, but you're going to develop tolerance to them. After a few days, those side effects go away. So you need to bear with it. Now, what you can do, though, is you can actually take the medication earlier. So if they're taking it just before they go to bed, it takes a couple hours for it to kick in. So it actually doesn't work right away. So, and then they're drowsy in the morning. So if they're going to bed at 10, tell them to take it at 8, or tell them to take it at 6. Or if they're at home after 6 in the evening, 5 in the evening, and they're not going out and they're just sort of sitting watching TV, take it then. And that way they're getting the benefit through the evening right into the night, and then they wake up and they're not feeling drowsy. As they get used to it, you can then get them to take it later and later at night, and then you can start increasing the dose if you need to. So these are things that you can do to tweak how they're able to benefit. Oh, and then second line, is tricyclic antidepressants. And really, you do not need to adjust doses in theory for tricyclics, but they do have adverse effects in terms of dry mouth, constipation, some of those things. It's those anticholinergic side effects that our patients already have, and we don't need to make those worse. It can cause conduction abnormalities in terms of heartbeat. So our patients actually tend to get benefit at low doses. So the same philosophy applies. If you need to use a tricyclic, we are going to start at low doses and titrate slowly. So a lot of people would use amitriptyline, and you can, but doxepine probably actually has a better adverse effect profile. So start at 10 milligrams and just keep it there. I wouldn't go more than 20 milligrams. And you'd only use it if you reached maximum dose of gabapentin and it wasn't effective. You would stop the gabapentin and try your second line. Okay, questions about that? Questions from anyone at the other sites about the medications for itch? Okay.
Benadryl and things don't get
Oh, thank you for that. Right. So do we see anywhere antihistamines on there? No, we don't. And actually, because your question is so commonly asked, and for so many years we prescribed antihistamines for it, you will actually see on the website right up front, antihistamines is not a treatment for itch. So itch in the general population is often related to an adverse reaction. It is related to a sort of hypersensitivity. I don't want to say necessarily allergic reaction, but an allergic type reaction. And that's then release of these chemicals from mast cells. Yes, that is what antihistamines are for. So if they're itchy from a contact dermatitis, allergic reaction, oh, go ahead. But this is for uremic pruritus, and there is no evidence for any mast cell release. So thank you so much for bringing that up, Deborah. So none. Now, there is a caveat to that. Atarax, so we would use Atarax is a first generation antihistamine that we've used for years for this. Is there a benefit in our patient population? Well, Atarax, and this is in the website if you actually follow the guidelines, Atarax is actually used now as an anxiolytic. So it's used for anxiety. So if you have someone that actually has a lot of anxiety and is also near the end of life and has some other issues, that anxiolytic, so Atarax, can actually be used more terminally for itch, especially if they've got concurrent anxiety, same as other benzodiazepines. So that would be the one caveat. So excellent question. Thank you. Other questions? No? So moving on to fatigue and sleep, I think this is one of the toughest to deal with. We do not have a magic bullet. So when you're getting them to rate it, really try and put it into perspective. Is this something that is truly limiting what you want to do? And what is it that you can no longer do? Because then that will lead into these strategies. Because if you look at the strategies right up front, a lot of them are going, well, it doesn't make much sense to me. But if it's things like, well, I can't do my shopping anymore, try and normalize it, saying you actually don't need to be doing your grocery shopping. This is something that we need to get help and support for. There's all these online grocery stores that deliver now, or Superstore. They shop online or get their family or someone to do their grocery list online, and then they pick it up. We should actually, this should actually be part of it. But now more and more people are getting all their groceries online. And the elderly can do this themselves because they tend to order the same things all the time. The shopping list is created for them. They saw what they ordered last week. They click on the same thing. They maybe add one or two, and it's either delivered for them or they can have someone go pick it up. So it's a matter of normalizing what is it that they can no longer do. Some of the things are they like doing certain things at home, but they're used to standing up. Get them to have high chairs now that they can sit down. So it's a matter of working through these energy conversation or these energy conservation strategies about what it is that they can't do. So they're actually saving their energy for the things that they do want to do. So help them prioritize. And that's actually really important. Then it's going to come down to sleep. A lot of them are fatigued because they're not sleeping well. And when we look at sleep, why are they not sleeping? And it's going to come down to your other symptoms. They may have a sleep disorder, but it might be other things. They're itchy, they've got restless legs, they're in pain. So it's a matter of treating that. But the sleep hygiene is so important. And these things you do have to go through them with. And sleep hygiene does make a difference. Reversible factors, though, for fatigue and sleep. This is something that I really do want you to go and have a look at and use the tool for, because a lot of people forget for fatigue some of the contributing factors. Vitamin D deficiency. This is why we say we would actually still treat for vitamin D, give them vitamin D if they've got restless legs, fatigue, muscle wasting, because vitamin D deficiency is a common cause of fatigue and malnutrition in our elderly frail population, and especially in our patient group. Metabolic acidosis. This is why we still give our CKM patients CO2 if they don't mind taking that awful big pill. but they are fatigued, we correct metabolic acidosis. So this keeps in mind why we're actually still treating. And hyperphosphatemia also can contribute to fatigue. Go figure. So if they're really high phosphorus levels, that may contribute. And then we still want to check for hypothyroidism, maybe just doing T4 TSH once, making sure they're not hypothyroid. Go for it. And then malnutrition and anemia. And then other things that would really cause problems with sleep, if I've already said, anxiety, depression, pain, restless legs, breathlessness, all things that make sense that we have to address. That's why we look at overall symptom burden. And then maybe they actually truly have a sleep disorder. So, asking them, are they really heavy snorers? Do they wake up, gasping for breath, what have you? So they're all things to look into. Then it is pharmacologic therapy. So the big things here, so like Deborah, you had said, what about antihistamines for itch? What's the first thing we want to do for sleep? We typically provide a benzodiazepine. And if you look at the geriatric medicine Choose Wisely campaign, what's the number one thing they're saying? Avoid benzodiazepines. And why? Again, that same drowsiness, risk of falls, but they have such an adverse effect profile with not as good benefit. So the risk-benefit ratio for benzodiazepines is really not great. So we want to avoid it. So how many of our patients are on Imovane? It's our go-to, right? Yeah. And it really should not be. It's not to say we can't use it, but it's second, third line. So, and avoid over-the-counter sleep medications because it's too much of a risk for them to overdose because they just say, well, this is over-the-counter, it's safe, we don't know what they're taking, they're frail, they're fragile, let's avoid if we can. So what can we use? Well, this just makes our life easy. RCT, so randomized control trial evidence, our first line go-to is low-dose gabapentin. Now we know that, yes, it's got the same risk profile of falls, drowsiness, but it's got a much better risk-benefit ratio profile. But the key is starting low, titrating slowly, and all those things that I told you before. And what would be our second line therapy? Oh, look at that. A tricyclic antidepressant, endoxapine. So already we've got two symptoms that have the same first line and second line therapy, and they're two of our major symptoms. Isn't that fortuitous? So it means we can get comfortable with just a couple of, maybe even only one medication, gabapentin. But if that doesn't work, going to doxepine. Now, the same thing applies with the benzodiazepines. If you've got an extremely anxious patient, that's the patient that I would then, there is benefit of going with maybe a benzodiazepine rather than gabapentin for the anxiolytic. But these are things that we can talk about that's outside of the norm. And then, so it would be mirtazapine, zolpiclone is usually third line, and maybe you bump that up to second line, or even maybe first line if you've got the patient that is anxiety 10 out of 10. But I can actually only think of one patient in my entire practice that actually fits severe anxiety, because once I treat the other symptom burden, her anxiety levels truly go down. She doesn't have a primary diagnosis of an anxiety disorder. Right? And that's what we'd be doing it. And then what about melatonin? So I'm not a huge believer of melatonin because I haven't found it to be overly beneficial, but some patients do. And if they get benefit because they just need to adjust their sleep-wake cycle, and that's what this does. It just helps reset their clock. They're sleeping during the day and not at the night. Maybe this is beneficial. So you would just take lower dose, 2 to 5 milligrams, and maybe you just dose at 4 in the afternoon and at night before going to bed. So these are all things to consider that I'm happy to discuss with you on a one patient case by case, an email, call me, page me, what have you. But these are all strategies that we can use, but keeping in mind number 1, number 2, gabapentin, doxepine. So actually, before we go on, questions about fatigue and sleep.
My one patient, we changed the time of his gabapentin, and it fixed it.
Yeah.
He's now like more awake during the day.
Great, and
Yeah.
that's really, really powerful. You just probably had to move it on a little earlier, right? And he probably sleeps better because they fall asleep quicker. Because it could take a couple hours after you take the gabapentin. It's not a traditional sleeping pill that knocks you out. It takes a few hours, but it keeps you asleep. Okay, other comments, questions?
I know Dr. Brom in the past has, in my presence, mentioned melatonin to his patients a couple of times. So unlike yourself, he seems to be a believer in melatonin. So I'm glad you brought it up because I was wondering if it fit into that.
Yeah, so there is no good evidence to support it in our patient population, and to be honest, the evidence in the general population is pretty weak, but it's safe. And if you get benefit from it, go for it. So if you use it in appropriate doses, so again, the risk profile is low. So
It's naturally produced, right?
it is naturally produced, yes. But you can muck up your I would never say it's without risk. Everything carries risk. But the risk profile of melatonin is extremely low, and for that reason, you can absolutely trial it.
What could be the side effect of melatonin?
What's that? There really isn't too much of a side effect, other than you may muck up your own diurnal variations, but there really isn't too much. Okay, so then moving on to pain. All right, so the most important thing in pain is going to be determining, well, one, we want to determine cause. And so with your physician, is there something that's treatable that can actually be fixed? But a lot of our patients that have chronic or persistent pain, the actual damage has been done, and the pain that they're left with is actually out of keeping of the original damage, and there's often not a lot that can be done to actually correct the pain itself, so a matter of treating. The non-pharmacologic treatment of pain is really beyond the scope of this. So there are some strategies they can do in terms of imagery, visualization, stress release. They may go for acupuncture, acupressure, but all those other therapies like mindfulness, cognitive behavioral therapy, so CBT, has really actually strong evidence behind, but it's beyond the scope of what we can provide. Not even going to walk down there, but there are some things that we can do in terms of that handout that the patients may get benefit from. Beyond that, you're really having to refer them to a pain clinic for those other, or a psychologist for those other CBT-like interventions. In terms of pharmacotherapy, though, there are a few things we need to talk about. So the most important thing is, does this pain have a neuropathic component to it, or is it all nociceptive? So nociceptive being sort of that muscle, bone pain, dull, cramping, throbbing. It can still be sharp, but that would be nociceptive, and that would be what traditional analgesics would cover. So your Tylenol, then your non-opioids like tramadol, and then your opioids. But what is neuropathic pain? So neuropathic pain is really pain. It's because those nerve endings, now the nerves are damaged and they're sending pain signals even though there may be no damage left. So ischemic disease, diabetic disease, carpal tunnel, all of those have neuropathic pains, calciphylaxis, Steele syndrome. So that's the pins and needles, burning, if it's that cold, numbness, tingling, electric shock, all of those are signs of a neuropathic component. If you have any neuropathic component, most of the pain, I suspect, is actually going to be combined. But if you have any neuropathic component, you have to go after the neuropathic component first. The reason being, neuropathic component is not susceptible or really susceptible to typical analgesics. What is it susceptible to? Gabapentin. It is. it's susceptible to adjuvant therapy. And our adjuvant therapies, if you were non-CKD, the first line would be a tricyclic antidepressant. So there's been a lot of work done in diabetic peripheral neuropathy. But for our patients, number one is gabapentin, and number two would be a tricyclic, so doxepine or amitriptyline. So I'm hoping like you're beginning to get a little bit more comfortable thinking, I only have to get comfortable with one or two drugs that I can maybe start working with my patients and gaining experience with. The reason for this is if you have severe neuropathic pain, you could give them Tylenol, then hydromorphone, you're up in the dose and they're getting toxic and you're not on top of their pain. So this is opioid sparing. It doesn't mean you will treat it 100%. So if your gabapentin dose is not sufficient enough and you're getting benefit, but you are still having pain and you're not at target, then you have to add your non-opioids. If your gabapentin's just not working, then you have to stop it and switch to another adjuvant. So then you try your tricyclic. Then you titrate your tricyclic up. And then hoping that one of those adjuvants should work. But if it's not enough, you keep the adjuvant on, but you add Tylenol. And you add Tylenol then for the neuropathic and the nociceptive component. So we can go up to 2 extra strength Tylenol 3 times a day. That's 3 grams. And if your patient has pain around the clock, how are you going to prescribe the acetaminophen?
Extended release.
Around the clock. Right? You're going to prescribe it to, well, you could do extended release for Tylenol, you can, or you could just do TID. So extended release once or twice a day or around the clock, so TID. So you want to dose it around the 24-hour period. If, though, they get most of their pain on ambulation, so it's predictable pain, you would dose it an hour before they go shopping, or so time it so it's relevant. If the acetaminophen is not enough, you add a step 2 or step 3. Because again, we're opioid sparing. It doesn't mean the acetaminophen is not working, it's just not enough. You don't replace the Tylenol with the opioid, you add it. So if you then switch them to Tramadol, which is tramadol and acetaminophen, that's combination, or you can just add tramadol. If you end up going to a very low dose of Dilaudid, you don't take the acetaminophen away, because the acetaminophen and the gabapentin allows you to get away with really low doses of hydromorphone. If you take away those other layers, you might end up with much higher doses of opioids. Then they're constipated, they're loopy. Opioids make their itch worse. It may make their restless legs worse. It could interrupt their sleep. So we don't want that. So these other strategies are opioid sparing. So if we look, and actually just ignore me as I go through here. Yeah, I'm going to come back to it. So if we look here, itch, sleep, neuropathic pain, all similar first line. And if I were to put restless legs up there, what's first line? Gabapentin. There we go. So gabapentin is a wonder drug. However, gabapentin is going to become our worst nightmare if we do not treat it with the respect it deserves and dose it and titrate it appropriately, because we're going to have confused patients or patients who are sleeping all day, feel terrible, and are falling and breaking things. So it has to be used extremely carefully.
Some of these GPs out there,
it's really education. Well, let's think of what the full dose in normal renal function is: 900 milligrams TID. That's 2,700 grams. we are saying a max of 300 grams. It is a drop in the bucket of what others are used to prescribing. So we really want to stress that. So I said, it's a great drug if used appropriately. The other things I really want to stress, though, about pain. If we are treating pain, there are several key dimensions you must assess. One is obviously their intensity, but the other is their function, their overall symptom burden, their quality of life, and their adverse effects. And this is why we use our pain assessment, because it's really based on the brief pain assessment. It really ables to track the severity for you. It tracks their function and overall domains of quality of life. And the other thing is, it actually, on number 6 there, it asks them what are their goals, and number 7, what is an acceptable level. This is so important because some patients have the expectation you can get rid of their pain and that, or get rid of any of their symptom. That is neither necessary or actually possible in many of the cases. And the vast majority of patients, if you can get their pain or any symptom to a 3 or less, their improvements in quality of life are dramatic. It's substantial. So it's neither possible or necessary to completely ameliorate the symptom. But if you can explain that to them and negotiate an actual, an acceptable goal and target, you will find that their satisfaction with their care is much improved, and they're also more adherent to their therapy. So it's setting up that expectation so you can actually achieve it. But that is really key. Now, if they have no neuropathic component, it is all nociceptive. It's basically going to look the same, except we're not using gabapentin. You're going to start with acetaminophen or topical NSAIDs, so all your diclofenac gel if you've got a small joint, and then adding a weak opioid maybe, or adding a very low dose of a strong opioid. Like hydromorphone. And then I'm not going to go into how to switch from hydromorphone to the other opioids, because that's for you to work with a nephrologist, but I'm always available to help rotate if need be, so to switch to a buprenorphine patch or a fentanyl patch, or prescribe methadone if we need to.
So could I ask a question?
Mm-hmm.
The acetaminophen, how long? You're talking indefinitely?
Yes, you can use, so again, a great question. You can use acetaminophen indefinitely, 3 grams a day. That's why we're maxing it out at 3 grams a day. The general population maximum dose is probably a little bit closer to the 4 grams a day. We're saying 3 grams. But yes, it can be indefinite. Now, so can the strong opioids, but I am going to caution you. There are, because with good treatment and managing all the other symptoms, the vast majority of our patients are going to get away with low doses. However, there are no, like I repeat, no studies of long-term use of opioids in our patients. However, for those at least on CKM, the risk of addiction is minimal, and truly those with pain and true high symptom burden on low dose, the addiction will remain minimal. But they still have all the other adverse effects to deal with, constipation and all the other things. So we want to do all our opioid sparing strategies to keep the dose low. Pain changes, and their pain requirement medications change. This is why it is so important to keep doing ongoing assessments to make sure that their requirements haven't changed. One, they haven't gone up and they need more. They are not building tolerance, which is not dependence. That's not psychological dependence. That is physical dependence. And they will become more tolerant, and they may need slightly higher doses. That happens over many, many, many months. But sometimes the pain actually improves because you're dealing with other symptoms, and you can back off on their medications. We want to make sure they're safe. So you always have to screen for adverse effects. Make sure that it's truly improving their function and quality of life. Because if overall symptom burden has worsened because you've got them on an opioid, You're not doing them any benefit. But the chances are, if you're going after the other symptoms as well, that is going to be in of itself opioid sparing. If they are sleeping, they've got a better mood, they no longer have restless legs and they're itchy, they are more psychologically able to deal with pain, and their pain perception actually decreases and their opioid requirement decreases. Everything works together. So that's why it's such a relief that we've got gabapentin, helps them sleep, helps them deal with their neuropathic pain, restless legs, and itch. But it really...
Do you monitor the liver function at all then? Or what if you have a patient, like I do have a patient who had a liver transplant? So
Yes.
acetaminophen might not be the best choice for them.
Yeah, so we'd actually, so I've got one, she's probably my patient. So I've actually got a couple and who are liver transplant patients, and we don't use acetaminophen for liver failure. Now, just because they've got a liver transplant doesn't mean they can't use occasional acetaminophen, but we wouldn't give them a chronic acetaminophen load. Also depends if they got normal function. If they've got normal liver function, they should be able to handle some acetaminophen. So we talk to the hepatologists as well. So just keep in mind, at the end of the day, we're not just treating numbers. We're treating our patients. We're treating how they feel, and at the end of the day, we want them to feel better. So I'm going to urge you to, at the point of contact, to really try and use the algorithms, because it really does help you walk through those reversible factors, walk through the handouts with them, and that non-pharmacologic strategies. But I'm hoping that with time, at least even for those first 3 symptoms and maybe even restless legs as well, you feel more comfortable with the pharmacology and you can talk to the nephrologist, because we should be on top of those symptoms. They are treatable and they're relatively easy to treat.